We got
On
the
3.
EKG. Our EKG says we have a ST, elevation myocardial infarction. The STEMI, that's our emergency. That one says we have a full-blown occlusion in that coronary artery. Door to cardiac cath lab is 90 minutes.
Meaning as soon as the patient walks in the door to the cath lab.
Yep, as soon as they hit your door, they have to be in the cath lab within 90 minutes.
What happens if that's 7 minutes?
Their chances of surviving decrease.
Yeah.
If you do not have a cath lab, you work in some little poor town and there's no cath lab there. What can we give them?
Thrombolytics.
Yes. So if no cath lab, give them some thrombolytics. And sometimes you'll see this as fibrinolytics. They're the same thing. These are your clot busters. They bust them up. They end in ASE. So you can have alteplase,
Fibrin.
streptokinase, relatoplase, or they end in ASC. If we're giving these thrombolytics, they have to be given within 30 minutes. Given 30 minutes from the time they come in. If we give them thrombolytics, what do we have to monitor them for?
Bleed.
Yes, monitor for bleeds. And where do we worry about bleeds at?
No.
Brain.
Brain.
So how do you assess to see if they have a brain bleed?
Neural
New
assessment.
neuro checks every 4 hours on these
Monitor
patients'
bleeds
Neuro checks Q4.
in brain.
If you have a patient that's had a prior bleed, they cannot have thrombolytics. If they've had a bleed before in the brain, do not give them thrombolytics. Cath lab, thrombolytics, please. Okay. If your patient goes to the cath lab, we're in that cath lab. What is your nursing care of that patient going to the cath lab?
Consent.
Yes, you gotta consent them. It's gonna be NPO. If you work in the cath lab with this patient, patients that have CAPS are at a high risk of AFib. So you have to have them on a monitor. You're going through their groin, you're putting something in that groin, and you're tickling the heart. So that throws them into these dysrhythms. That's why they have that AFib risk. You gotta shave the groin using an electric razor. Don't use a regular razor. Then, they've had their cath, they come back to the floor. You're gonna be the nurse taking care of them. What is your first thing when they come to the floor? What's the first thing you do for a cath patient?
Check for bleed.
Check for something. So bleeding is pretty high up there, but it's not the first. What do you say? We're gonna check distal pulses. Because remember they're going into the artery.
Yeah.
So we gotta check distal pulses first.
That's the first thing you do?
Yep, we check. You will have nurses that are send a CNA in and get vital signs or whatever, but your priority is making sure those pulses have returned. Let's go over here. Can I erase? When they come from the cath lab. Number 1, check pulses.
On both extremities?
Mm-hmm. Yep, you wanna do a comparison. If you cannot feel a pulse, then you can do a Doppler, but we need to be calling the physician and letting them know that something's not going on. Then we're gonna check for bleeds. So when we're checking for bleeds, we're gonna look at an incision site, but where else can they bleed?
You said it.
Retroperitoneal.
Retroperitoneal.
And how do you know they have that bleed there? They'll start complaining of back pain. And sometimes you can see that blood is starting to pool, depending on
In the
your
back.
patient. So retroperitoneal is like right behind
And
the
why would they
kidneys.
bleed back?
Because that femoral artery is kind of close to their, renal arteries, and sometimes they get poked. So we're checking for bleeds. They're bleeding to the back. It goes around the back, and there's a lot of stuff up here. How do we stop a bleed?
Fresh.
Yeah, so we want to have a pressure dressing.
You wanna have it
Yep,
at the bedside?
they should already have one on. If they do not, you put pressure on them. So there's some dressings that come that have pressure. If not, sometimes you use a sandbag.
Mm-hmm.
That's not on the test, I don't think, but, you know, that's a pressure dressing. And when we put our pressure dressing on, we need them to be on bed rest, strict bed rest, 24 hours. That leg has to remain straight. They can't get up and go to the bathroom. They don't do nothing. If they gotta use the bathroom, they use a bedpan or they use a urinal. In the hospital, you will see some physicians, because now with the cast, they do send them home sometimes same day, but this is what your booking includes. I think it's
Huh?
99.
Dollar store? Look at this thing. I don't know, it's like a little holder. It's from the dollar store. Look at it though.
Okay, did I erase before y'all were ready?
No.
I'm sorry.
What do you use it for? Is this the purpose? Oh.
When I'm Zoom, because my computer
Oh
is
my
moving.
gosh. Wow.
Heart failure, cardiac. MRIs. Whoa. What is infective endocarditis?
An infection in the lining of the heart.
Yes. What are our high-risk patients?
Post open heart? No.
No.
Endocarditis.
So patients that are at risk for getting infective endocarditis are gonna be your IV drug users, your hemodialysis patients. Why hemodialysis patients? I can't read right now. This is- That's a direct, that's a direct sight into the heart. So, all those little microorganisms have a direct path to get to the heart to give them infective endocarditis. So hemodialysis, long-term central IVs, and your IV drug users are gonna be high people. And those who do not have good oral hygiene.
Really?
Mhm.
Why?
In your mouth, your, up in here, this facial piece of it or whatever, it goes, when it drains down, it goes into the heart. So they're your patients who have poor dental hygiene, so if they have a lot of cavities, they have a lot of abscesses, they end up with infective endocarditis. So you have to look at your patient's mouth and look for cavities and all that. And those with this, sometimes when they're having procedures, they'll go ahead and give them some prophylactic antibiotics because of that. So how do we treat these patients? Well, first, before we treat them, we gotta diagnose them. We know who's high risk. So when they come in and they're complaining of chest pain, what do we do first for patients complaining of chest pain?
EKG.
Yes, gotta do an EKG. EKG comes back, it's normal, we're not having an MI. Our second step is going to more than likely be a TEE, a transesophageal echocardiogram. So with your TEE, this patient is going to be sedated. You have to have consents for them. When they come back to you from having a TEE and sedation, what is your big concern for these patients?
Gag reflex.
Yeah, check that gag reflex has returned before giving them anything to eat or drink. For patients that have infective endocarditis, a complication for them. What happens is they have vegetation. Complication. They have vegetation on those vessels. That vegetation can break off and go to the lungs, the heart, and the brain. So,
Stroke?
yep. If it breaks off, they can have a PE or a pulmonary embolism. They can have a heart attack, and they can have a stroke from that breaking off.
All from having a cavity?
If that cavity
Oh, I
leaks
noticed.
infective endocarditis,
Wow, really? That's terrible.
so you need to get those fixed. Because if it ends up here, then you can end up here. And
Jeez.
so,
How does it go to your lungs? I don't understand that.
cause there's vegetation, so anytime you have an infection, what happens? So what's part of the infection process?
It spreads.
Well, you have those neutrophils, so your immune response, so the neutrophils kind of rush to that area trying to fight that infection off, and they start to pile up. So when they go into your heart, those vessels are kind of small, and they could just stick there. It's infected already, and then those bacteria stick even more to the neutrophils that are there trying to help. And then you end up with vegetation. So vegetation is from your red blood cells, white blood cells, and bacteria clumping together. And if it breaks off, it can clot. It causes a clot when these things break off. Cause your arteries are not that big up there. So what is treatment for these patients?
Long-term antibiotics.
What's long term?
More than 4 weeks?
6 weeks is kind of sort of the norm. 6 weeks IV antibiotics. And your patient can have pericarditis. Pericarditis is this inflammation in the pericardium.
Would your WBCs show the infection at least, or no, it would just be chest pain?
Hmm?
They would show.
White blood
elevation?
cells will be elevated, but you don't just go by white blood cells because that's gonna elevate with any type of infection.
Okay.
Same thing with your SED rate or your C-reactive protein. They're always gonna be elevated when there's inflammation. The pericarditis, the pericardium's inflamed, nursing care is just gonna be around treating that inflammation and that pain. So we're gonna give them some NSAIDs. They may get some IV, narcotics. This kind of depends on the physicians. And positioning is really important for a patient with pericarditis because it does cause a lot of pain. Do not lay these patients supine. We wanna put them on their side
Why?
for the chest pain. It hurts
Because
more
of
when
pain?
you-
Okay.
And with pericarditis, that's all they're having a lot of times is that inflammation, so we wanna give the body time to get the inflammation down. So we're just treating symptoms.
Okay.
Pericarditis, endocarditis. Cardiomyopathy. What is cardiomyopathy? What's happening?
Muscle heart.
What with the what? Muscle? Did you say the muscle?
Is dying.
They're huge, So they have big hearts. Cardiomyopathy is an enlargement, and it's typically those ventricles that are gonna be affected. So with these patients,
So what's enlarged?
the ventricles,
Okay.
Start writing it, it'll come to me, I'm sure. I should do better notes. Cardiomyopathy. Affects ventricles. If our ventricles are trying to contract, and they can't, because the heart's too enlarged, the heart's too big, and the contraction's not enough, they don't get the blood out to where it needs to go. If the blood's not going out, what are we missing? What is happening to the patients?
Low cardiac.
Low cardiac output, which is going to affect organ perfusion.
So the ventricles are not powerful enough to pump blood where they should.
Because they're
Because
too
they're
big.
Mhm. And that muscle starts to stiffen up the bigger it gets.
So,
Decreased cardiac output, decreased organ perfusion. The main organ that doesn't get perfused when we have cardiomyopathy,
brain, oh, kidneys.
so what are you gonna assess for your patients that have cardiomyopathy?
Your
Urine output.
Yep, they're gonna have a decreased urine output. They will not filter. Oops, they will have edema. And it can lead to heart failure. What tests are we gonna look at for our patients that have cardiomyopathy?
kidney function.
Everything. So forget all of this other stuff for the moment. If we're trying to find out if our patient has cardiomyopathy, what test?
Is it the T? No.
Echo.
Echo to look at the ventricles.
Yeah, you got an echo, you gotta
Right.
see the picture,
Echo is the picture.
yes.
Okay.
And if we're doing an echo, which patients concern us? What medicine are they taking?
Metformin.
Yes.
Oh, because of the, we have to give the, what is it? The contrast?
Yeah, patients taking metformin, hold.
That was on the test.
Yes, it was, you were right.
That was on the test.
We're gonna hold it for 48 hours. If they are not in the hospital, we can't really control when they get it last, but if they're in the hospital, it's not an emergency. We wanna, hold it 24 hours before the test and 48 hours after the test. But if they're just coming into the hospital and they're having some chest pains and the doctor want us to do an echo, then we can't hold it. We're just gonna hold it after. It's more
Hold
important
it
to hold
after,
after than before.
okay.
Yep. Cardiomyopathy causes which other condition? I just told y'all. Heart failure, thank you.
Oh.
I didn't write it, so that's why I was like, wait. what am I saying? So, yeah, cardiomyopathy can cause heart failure, so know the signs and symptoms of that too.
And what do you treat that?
Mhm. I said, know the signs and symptoms of the heart failure.
I mean, what do you treat it? Medication,
What is it?
treatment.
It depends. So if they have the heart failure, then we're gonna treat the symptoms of heart failure. Most of these patients with cardiomyopathy, are gonna end up needing a transplant. We're trying to decrease their preload, so how much blood is coming in, because they can't get it all out. So we'll give them, some Lasix, some diuretics, because it helps with volume. So preload for them is all about volume. Johnson, heart failure, pericarditis. AAA, what is a AAA?
Aortic, abdominal aortic aneurysm.
Yes, abdominal aortic aneurysm. How do we find these? On accident. The patients have something else going on, and they are usually found because they either have some nausea and vomiting that hadn't gone away, and the doctors will do a CT scan on them, and then they'll be like, oh, you have an aneurysm. So when do we treat these patients?
When it's larger than, is it 5? 5?
Treat with surgery. I think your book says 5.5. I say 5, but look at the book. Treat with surgery when greater than 5.5 centimeters. If it is less than 5.5, we're going to treat hypertension. Because if we can keep that blood pressure down, and there's not so much forceful pumping and so much going through those vessels or fighting to get through the vessels, then we can kind of control this. So when we do surgery with these patients, well, before we do surgery, if you have a patient that has a AAA, the major complication for AA is rupture. If these patients rupture, that is an emergency. If they're at home, most of the time they don't make it to the hospital, they die. So this is why we have to keep an eye on the size of these so that we can prevent rupture. So how do you know that your patient ruptured if they're in the hospital? What's the sign? It's only one that you gotta worry about.
Major pain, I guess, right?
Major pain where?
In the shoulder?
Severe back pain. Lower back pain. So severe lower back pain lets you know this patient has had a rupture.
And you already know this patient has an aneurysm.
Mhm.
So severe lower back pain
Yeah.
equals rupture.
You have surgery and you fix it, yeah?
Yep.
Okay, cool.
Yeah, so you may have to do open heart surgery on these patients. They may have a cabbage, and some of your patients who have,
The diagnostic
MRI?
part, what were you gonna put there?
nothing. You find it on accident.
Okay, so it's accidental.
Yep, you find it because something else is going on with these patients. Now, once you know they have it, they do monitor them by doing either MRI, CT scan with contrast, every 6 months or so for a couple of years, just to kind of keep an eye on it. So your patient has had a MI. We take them to the cath lab does not work. We are going to do a cabbage, so we're gonna do open heart surgery on them. What are your concerns for your patients that have a cabbage? This is not in the correct order, of course. AFib should be first. Patients that have cabbage, high risk for AFib. To get them out of AFib, we are going to cardiovert them, or we're gonna kind of shock them sometimes. But cardioversion, they're at high risk for infection. When these patients are going home, DC instructions. They just had their chest split open. What are you gonna tell them?
Pain.
Yeah, we wanna control the pain. No heavy lifting, because we don't want that to split open. No twisting, upper body. No driving until cleared by the doctor. And when can they have sex?
6.
When they can walk up the stairs.
Yep.
No
And come back.
driving.
Resume sex when able to climb 2
No driving.
flights stairs without being short of breath.
Oh my
I'll do
God,
this next.
I can't even do that.
Did you say you're hot?
I said I can't even. I'm
Oh.
one flight of stairs and I'm like. It's true.
Abstaining for a very long time.
Oh my God.
Ay.
So, Your patient has a cabbage. These are our discharge indication. These are our two biggest concerns. Some of my patients we're gonna send for a stress test.
There goes the sex.
If we send patients down to have a stress test,
Mm-hmm.
we're gonna be working that hard. The heart's gonna work extra hard. Before they go to the stress test, we wanna see how much stress this heart can take. So what do we do before that test? No caffeine. No smoking. No meds that decrease their heart rate.
But they can have their blood pressure raised.
Depends on what it is.
Right.
So if it's something that's gonna bring down their heart rate, no. We don't want anything that's gonna help the heart to be able to kind of function more. We wanna get a true picture. Inside of that stress test, we're working that patient heart. We already know they got cardiac disease. What are they at risk for? Heart attack. So what do we need to have?
Defibrillator.
Have defib available. I think that's all. With that. Now, we just have a couple of medicines that I want you guys to know. I think I did all the disease processes.
What was the two ones that really could shock the patient? Was it the AFib and what else? What was the other one?
VFib, VTAC.
Mm-hmm.
VFib, VTAC. For your patients that, have AFib, where am I looking? Oh, if your patient has AFib, which electrolyte is more than likely responsible? Potassium. So they have, AFib, or if they have a cabbage, or if they've had a cardiac cath, we need to be watching their potassium levels to make sure that they do not. And with AFib, what kind of, shocking are we gonna do? Are we gonna defibrillate them?
AFib, no.
What is it called?
We're not gonna get them atropine.
We're gonna do cardioversion.
Cardioversion with AFib
Yeah.
and A-flutter? Or just
AFib.
AFib cardioversion?
And what is cardioversion?
It's synchronizing the heart.
Right.
If your patient is unarousable and you can't get them up, then it's kind of sort of like a shock, but not really. There are some medicines that we do that are cardioverting, and it's usually your calcium channel blockers. They can do the cardioversion too. And your patients who have mitral valve regurgitation, a complication for them is heart failure. That's their major
Mitral.
complication. 'Cause
Mitral.
remember that blood is regurgitating, or it's going back, it's not going where it should, so they end up with heart failure. So, again, know the signs and symptoms of heart failure.
Mitral valve regurgitation, what was it? Can you repeat that?
The complication is
Mhm.
heart failure, to know the signs and symptoms of heart failure. Alright, let's talk about medicines and then you guys are free. We talked about the Johnson. Right. We talked about the HCTZ, right?
The what?
HCTZ, the diuretic.
No.
We talked about diuretics.
We talked about diuretics, but not that one.
HCTZ.
I don't know.
You can give them both sometimes? I didn't tell you
No.
that? Oh, that must have been this morning, sorry. So HCTZ is your second diuretic other than your furosemide, and sometimes they have to combine the two to diurese your patients. But it's the same thing, you're gonna watch for those potassium.
HCTZ?
A hydrochlorothiazide.
Mm.
Lisinopril, verapamil, atenolol. What type of medicine is atenolol?
Beta block.
And what are you concerned with patients taking beta blockers?
Orthostatic hypotension.
Yep. How long do we take their blood pressure? Yep, you have to count that heart rate for a full minute. Count 1 minute, apical. If less than 60, hold, notify PCP. Verapamil. Medicine is that one? Calcium channel blocker. What do we worry about with our calcium channel blockers?
Low pressure,
So one more time,
low blood pressure, low adrenaline.
heart rate. Blood pressure, not as much, but that heart rate, yes. Low heart rate. Muscle cramps and weakness.
So, you get, if you were having those symptoms, you would get, is it like a lab to see your electrolytes? Yeah, correct.
Well, you don't even have to do that, you don't have to even go that far. If they have, if they're getting calcium channel blockers and they start complaining of muscle cramps and weakness, then you're gonna notify the physician. Lisinopril.
But I don't think that was an option.
Oh. It was not an option?
No, I think that it's, what would be your assessment, like, what would you, like, one of the things that you would, like, how would you assess for that?
You would get a serum of electrolytes.
Serum electrolytes.
Which one do you think?
For that.
For that,
What
how would you
test?
assessment?
Intervention.
Which, what do you think is gonna be low? It's gonna cause,
The calcium.
yeah, the calcium. It blocks those calcium channels, so it can't up. So lisinopril is an ACE inhibitor. So any of the pril, ACE inhibitors, olol, or beta blockers. So depending on, you may get atenolol, you may get propranolol, I don't remember. Just know that if it's OLOL, it's a beta blocker. If it's PRIL, it's an ACE inhibitor. Your calcium channel blockers usually end in PINE. There are a couple that don't. So verapamil, your cardizem, they don't end in PINE, but they are calcium channel. You just have to commit those two to memory because you want to look at that muscle weakness and checking the heart rate. ACE inhibitors. What are our concerns with these patients?
Angioedema.
Angioedema and then dry hacking cough.
Mm-hmm.
If your patients have angioedema, you will normally see this in your African American patients. They will have the lip swelling, but not always. Sometimes angioedema starts in the throat. You get bronchospasms in the throat. So you may feel like there's something in there, you can't get it out. It's like a tickle and that's one of the first signs that they may be getting angioedema. And the patients should be taught that. If your patients can't take ACE inhibitors because of angioedema or the cough, what can we substitute? Yes. Substitute, okay. Substitute an ARB for an ACE. Good. I think that's it. Let me go back through my notes just to measure. Varicose, venous insufficiency, heart failure, endocarditis, mitral regurg, cavity, patient with lisinopril, DASH diet, left-sided heart failure. Complication from left-sided heart failure. I don't think I told you. So complication for left-sided heart failure. It's affecting the lungs, right?
Mm-hmm.
So what's the complication? What happens in the lungs? Pulmonary edema. Left-sided heart failure, a major complication is gonna be pulmonary edema. And your sign and symptom for that is gonna be that pink frothy
Oh,
sputum.
that's right.
Is pulmonary edema?
Mhm.
I was like, what do you mean?
Yeah, they have a
Pulmonary,
pink
Remember
frothy
now,
sputum, and then
yeah.
you can hear the crackles, of course, in there.
pink frothy?
This
Have
is
you
for
ever
the
seen this?
herbs, right?
Mhm.
Is this for the herbs, that one?
No, that's
for heart
just
failure.
pink frothy
Complication from heart
sputum.
failure.
What is, what
Which
else?
medication is it though again?
It's not a medicine.
It's just a
That's
complication.
failure.
So,
Oh.
wait, so pulmonary edema, you're gonna see the pink frothy sputum
They can have
and
some dyspnea, they'll have
Dyspnea,
crackles.
crackles.
Pink frothy sputum is your key.
Okay,
Test for
dyspnea.
pulmonary, right, left, pacemaker, VH, heart failure, teaching pericarditis, AAA diagnosis, MI, stress test.
Oh, does it have-
Raynaud's. So your
What?
patients that have Raynaud's disease.
Renal.
Yeah, I almost forgot Raynaud's. That's why I had to look back at my sheet, because I can't remember.
Yes, please keep looking at it, please.
So your patients that have Raynaud's disease, you wanna teach them to avoid temperature extremes and any medicines that's gonna be vasoconstricting. So a lot of these are medicines that they're gonna buy over the counter, such as a pseudoephedrine, because they do vasoconstriction. Your patients that have Raynaud's have an imbalance between vasoconstriction and vasodilation, and that's what causes their pain. So those are your big two.
Avoid temperature changes,
Extremes.
temperature extremes,
Not
and
too cold, not too hot.
vasoconstricting meds,
Yes.
such as the Sudafed.
Sudafed. If your patient has to have a pacemaker placed,
Mhm.
how do they care for themselves with a pacemaker? What do they avoid? Magnets.
Mm.
So if they're going through the airport, they don't go through the scanner. They don't have MRIs. They can use a microwave. I don't know why everybody thinks pacemakers mean you can't use a microwave. You
My
can.
grandmother would've-
They can use a microwave. What is a cardiac tamponade?
When it's not quivering, but it's not beating,
And what causes that?
Hmm.
That is a build up of blood or fluid around the around the heart.
that doesn't let it beat.
Yep.
Correct.
Build up of fluid or blood around the heart. So, when you are listening or when you're assessing your patient, you will hear muffled heart sounds, because you can't hear through that fluid. And because blood is building up, it's gonna start to back up because it's not going where it's supposed to. So your patients will have JVD, or jugular vein distension, and they will have a narrow pulse pressure.
Narrow pulse pressure? What,
So that's
what
when you
is
check
that?
their blood pressure. And you get the systolic, then you look, and again, you get the diastolic, and you're gonna take the diastolic from the systolic, and if it's less than 10, then it's
Mm.
narrow.
Okay.
I think that is it. I've looked through my.
Can you keep looking? What about the other one?
That's,
That.
what I want y'all to know about that. Whatever those things.
Can you email us if you think of anything in your sleep?
No, this came straight from the test. This came straight from your exam.
Thank you.
I sat and looked at it while they were testing this morning. So what is this again?
Oh, yeah.
Yeah. Uh-huh.
Okay.
Yeah, you can pack up, but you're gonna get this.
Thank you.
I'm sorry, it's after 9 and I said.
No, go for it. Thank you.
Alright,
Okay.
What is,
VFib.
V-fib.
V-fib,
Mhm.
alright.
A-fib.
Tacky.
V-tach.
V-tac.
V, oh,
V-tacky. They're tall.
alright. What,
Mm.
if you have, if you have this, you have 6 of those,
Mm-hmm.
sorry, let's not do that. We could do that, but if you have 7 of them, good. If you have this and you have 15 of those,
Tacky. Sinus tacky.
and if you have 3,
Brady.
Ready?
and if you have 3 of them and your patient has nausea and vomiting.
Atropine.
Give them atropine, good. What is? 1, 2, 3. 1, 2, 3.
Mm.
If you,
Hey, which one?
Atrial,
Those?
Flutter, multiple P's.
Yeah.
atrial flutter.
Flutter. Some places you'll see them look like, kinda like that, cause they call it a sawtooth pattern. Some of them are gonna be rounded. I like when they're like that because you truly know that it's a flutter, but whatever. Alright, and yep, that one's AFib. VFib, VTech, AFib, a flutter, and we did the normal and the Brady. If your patient has supraventricular tachycardia, what do we do?
Adenosine.
Good. If your patient has AFib, what do we do to get them out of that rhythm?
Cardioversion.
And what's the medication we can give for cardioversion?
Mm.
Calcium channel blockers. Calcium channel blockers. If your patient has VTach or VFib, how do we get them out of it?
Shock.
Yeah, got a VFib. All right.
You think we're ready?
Yes, y'all done good.
Okay.
It's only 5 of them.
Mm.
The housekeeper in this